And we're live in 5, 4, 3,
2,
1.
Good evening, everybody. My name is Jens Chapman, and on behalf of our Texas Back Institute friends and colleagues and Jack Ziegler, our co-host, we welcome you to this edition of An Evening with a Spine Surgeon. Today is August 9th, 2023, and this is a particularly cool evening because tonight's guest is one of our personal heroes, Dr. Ed Benzel, Chairman of Department of Neurosurgery and one of the true interdisciplinary leaders of the specialty, neurological surgery and orthopedic surgery. And this is a great opportunity for us to learn and be inspired from one of the true greats in our field who's influenced in so many ways. Dr. Jack Ziegler has put together a little bio so that everybody's on the same page, and then without much further ado, we'll have the star of tonight take center stage, just like he's on the screen here, and talk to us a little bit about what inspired him and how he got to where he is and where we should go as a specialty. So thanks for being here, Ed, and Jack, take it over.
Thank you, Jens. You didn't get the memo to grow a beard like Ed and I, but I'm just delighted to have Dr. Benzel here. The whole focus for this program is really to introduce everyone in the spine world to people that have helped make it the dynamic specialty that it is. So just a very quick introduction to those of you who may not be as familiar with Dr. Benzel as we are, is that he was the professor in chief of the Division of Neurosurgery, University of New Mexico, for 10 years from 1989 to 99. He then moved to Cleveland, where he was the chairman of the Cleveland Clinic Department of Neurosurgery for 9 years from 2007 to 2016. And since then, he has been and continues to be the emeritus chairman of the Cleveland Clinic Department of Neurosurgery. If we go to the next slide, just a quick bio is that he is from the Pacific Northwest. He was born in Spokane. He is a chemical engineer by undergraduate degree, and then spent a lot of time in the Medical College of Wisconsin, where he got his MD, did his general surgery internship, PG 1 year, neurosurgery residency, and his fellowship in spine surgery and spinal cord injury. Next. Dr. Benzel has one of the most amazing CVs I've ever seen. It's a dense, meaning no fluff, real CV, but he's just such a humble guy. He doesn't want to talk about it, but he has authored 10 textbooks, edited 27 more, has written more than 400 chapters, has almost, or probably more, than 400 peer-reviewed articles published. He's made over 700 presentations, and really the shining achievement for all educators is that he has touched the lives and trained hundreds of residents and fellows, and has just won tons of awards. So if we go to the next slide, I'm going to quickly turn it over to him, and just to tell you my personal impressions of this man who I've had sort of a tangential relationships with over 4 decades is that when I first heard him speak, I said, this guy really gets it. He gets biomechanics of the spine. And every time I've heard him speak, I get more and more convinced that that was the right first impression. The next bullet is despite that, he's just an incredibly approachable man. And the last is that he is just a good guy, just a genuine, caring individual, and our pleasure to introduce to you. So, Dr. Ed Benzel, thank you very much for being here. It's an honor for Jens and I and all of our colleagues and all the attendees. So if you just want to lead off a little bit, tell us a little bit about growing up and maybe what directed you to go into a field in medicine and take off, and we'll stick our fingers in every once in a while if we have a question or want you to redirect a little bit. So thank you again.
Well, thank you, Jack. Growing up, that was so long ago, I can't remember. I grew up on a farm. We were poor farmers, and all I knew is that I wanted to get out. And college was the only way out. And I got into college, and I was interested in engineering and math, and I did a summer job at the Hanford Atomic Energy Commission. and realized that chemical engineering wasn't for me, and decided I was going to become a doctor. Took all the courses necessary, and lo and behold, I got accepted at the Marquette. I applied to Marquette Medical School and was accepted at the Medical College of Wisconsin. They went from private to public in that interval during my application. My path to spine surgery started with my residency. During my internship year, I did an internship in general surgery. I rotated in December on the neurosurgery service. And I was very impressed with my chairman, Sanford Larson, and what neurosurgeons did. And what neurosurgeons did at the Medical College of Wisconsin in those days was akin to what orthopedic surgeons were doing around the country, and much strikingly different from the standard cranial prototype that was present in most institutions around the country as far as neurosurgery. And so I became enamored with spine surgery, and I spent an extra year there, and arguably was the first neurosurgery spine fellow. Then I went to Shreveport, Louisiana, LSU. And I know that one of the questions that I potentially was going to be asked is, who are my mentors? And I was talking to Izzy a little bit about this before we started here. Sanford Larson was truly a mentor, but he was not a good teacher. But he set the table. And from him, I learned so much. But then as I left, I went to LSU Shreveport. After I left the fold, I went to LSU Shreveport and joined a single partner. There's no training program there. Very busy medical center. Two interstates crossed there, a lot of trauma. And about a year and a half after I arrived, my only partner left. It was from then on, essentially, that I was either the oldest or only for a short term, not the oldest person in any department I've been in. And so mentorship in its truest sense was not availed to me. And however, I gathered mentorship from faculty, residents, fellows, people who inspired me by just being them, and Izzy Lieberman being one of them, a critical person in that pathway that I took. Then I got the job of becoming chairman of neurosurgery at the University of New Mexico. I spent 10 years there, started a spine fellowship and a neurosurgery residency training program. And then due to difficulties with leadership, general surgery leadership, I left and came to the Cleveland Clinic in 1999, and I've been here ever since.
So let me go back to the pharma's background. So in our UW program, we did an analysis of success stories of residents that was orthopedically tinted. But the one really pertinent success characteristic that we found was farmers as a background. Being a farmer, how did that prepare you? Is that something that just creates this disposition towards problem solving, dedication, grit, ingenuity? Is that something that you see as a sentinel basic character forming experience?
I always thought that engineers and analytical people were the best applicants because they solve problems. But, you know, farmers, particularly if it's been tough, you have to be disciplined. You have to get up early. You have to work until there's no more sunshine. And so the discipline required to do what we do perhaps comes from, in part, in my case, from growing up on the farm.
And the way, follow-up question, by the way, we have Dr. Izzy Lieberman here, who's a former partner of Dr. Benzel, so we have a first-hand witness and colleague and fellow admirer. In terms of leadership, there are multiple leadership seminars all over, and for me, the key thing that Jack just pointed out is you're a very approachable man. How much can we teach leadership? How much is it just ingrained in you or circumstantial? How did you get into these effortless leadership roles, which are sometimes very difficult and very contentious? So where did you learn leadership?
Well, I think I learned it from the people that surrounded me, and I learned it from myself. Leadership, my favorite definition of leadership is the art of convincing others to do something they otherwise might not have done. And so we're all leaders. All the residents, the fellows, we're all leaders. We lead somebody. And we need to corral that energy in a noble way. I don't know how it happens. It happens to some people and not to others. And contentious relationships most certainly occur, as we all are aware. I mean, I left the University of New Mexico. I left LSU in Shreveport because things just weren't working out well. I'm not sure that was because I was a bad leader. It may have been because the chairman of surgery in both places was a bad leader. I'm not going to cast aspersions, but sometimes it's just time to go too. That's another way of looking at it.
Izzy, as a primary witness, how was working with Ed, and how did you experience his leadership style personally, especially under the angle of a almost impossible merger of orthopedic and neurological spine surgery groups? There were not divisions. There was a very powerful unit that was born out of that group at Cleveland. So how did you experience this leadership in action?
I'll sum it up with 2 words: integrity and credibility. Ed would always do what he says and says what he does. And if you turned your back, Ed would always do the right thing. There was never anything hidden behind it. So there was a lot of that. And he espoused that on all those that worked with him and worked around him. I was always fascinated by the way he involved everybody. No one was excluded in any of the projects, the meetings, the things that we did. It was just always open, always transparent, and everything was done with integrity and credibility. Over the years, I've tried to emulate a lot of what I learned from Ed. And I still use a lot of Benzelisms. Repetition is good. That's one of my favorite ones. Repetition is good. So there's a lot of stuff that you just learn being next to Ed, and it's almost osmosis. That's part of it.
So I use one of yours a lot too. Measure twice, cut once.
Yeah, I'm not sure I invented that, though. I heard that from someone else. So.
Well, it's okay. I attribute it to you. Take it.
Thank you for that. You see, that's what I mean. He's just always supportive, always inclusive. So there you go.
In that regard, Gordon Bell, who I think everybody knows here on the panel, and who's just a wonderful human being, once said to me, how did we pull this off? This business of combining ortho, neuro, medical spine, and now psychology and into one working unit, very functional unit. And he says, I think it's because you, meaning me, but I think it's true for everybody in our group, is very egalitarian. Of course, I had to go look that word up. But what it literally means to me, in plain and simple terms, is treat people just like you want to be treated yourself. We all put our pants on one leg at a time. That nobody's any better than any other just because they were trained this way or learn something another way or do something different. And so being egalitarian, I think, is a very solid characteristic of a true leader.
So if I can relate one story, one of the most impressive things about Ed, and it gets us a little bit of outside of spine surgery or spine medicine, the continuum of care. But Ed, do you still run your age on your birthday?
No, I quit that at age 64. I'm now 74. There's a point of limitations there where you really can't. There's not enough time in the day nor the energy to do that type of thing forever. It's an analogy there is a little kid on the farm. Every day he says, I'm going to go lift that calf up. And when that calf becomes a big cow, I'll be able to lift him up if I lift that calf every day. Well, I'm sorry, son. It ain't going to happen.
That's a great line.
So, Ed, let me ask you, how many did you run? 64 miles? Or
yes.
Was it?
Yes.
Really?
Really? Yes. But then I decided it was time to quit.
I probably would have quit after I was 5.
I started when I was 40, so with that notion.
One of the stories that I frequently tell, and Ed, probably you don't remember much of this, but we happened to be going to a spine meeting in Fort Lauderdale when we were both at the Cleveland Clinic. We both had just gotten there. It was within the first year and a bit that we got there. And somehow we booked the same flight, and we were actually sitting beside each other, and we didn't even know that we were both going to the same meeting. But when we got to Fort Lauderdale, I said something like, I think I'm going to go out for a run on the beach. And you said, yeah, can I join you? And I went, sure, whatever. So we go up, we get changed. I come down in my fancy Nikes, my running shorts, my headband. At the time, we still had Walkmans and my earphones. And I'm waiting. And Ed comes down in cutoff shorts, flip-flops, and a tank top. And I look at him and I thought, okay, whatever. We're going running. We go outside. Ed, you slipped off the flip-flops, you put them in your back pocket, and you ran barefoot the 6 miles that we ran, and I couldn't even keep up. It was like, you got to be kidding me. This guy's running barefoot out here, and it's just the unexpected from Ed Benzel. That's what it is.
Well, I honestly don't recall that, but again, I'll take it. It sounds like a great story.
It is a great story because Izzy's a very fast runner.
Yeah.
So,
well, I used to be a lot faster than I am now.
So again, the theme of egalitarianism and approachability, I think, is well resembled with this, because at meetings and just gatherings, or when Ed is on his many trips abroad, there's always a chance to run. There's a community building. There's a social event associated with that. So I just want to recognize the brilliance of this, but also what it means. Ed, talk about wellness. So we try to teach wellness to our surgeons. You always seem to be an unbelievably productive colleague. I mean, your editorialship, book authorships, great articles in literally every dimension that you can think of, not just surgery, but transcendental, mental, whatever aspects. You always had this tremendous balance and calm. So how do you do this? Is running your kind of a equipoise generator? Or what would you tell younger people as at the beginning of their careers and they're getting bombarded with demands, how to keep this equipoise?
First of all, people don't have to be runners. They can be swimmers, they can be walkers. But the important thing here is taking care of your body. Because each of us only get one. And we need to take care of it in order to function in the greatest capacity. But also, pick a great wife or partner. They're the glue that really hold things together. So I have a little bit of an emotional story. Maybe 6-7 years ago, I was honored at the Congress of Neurological Surgeons, and as part of the show, they got my wife and 4 sons up on the stage and interviewed them, asking them what it was like to grow up with Ed Benzel. And people learned a lot of things, including the fact that when I wear blue jeans, I don't wear underwear, which is one of my sons brought up. And the next to the oldest said he wasn't around a lot, but he was when we needed him. And I didn't realize that because I felt I wasn't around enough. And I'm sure I wasn't. One of the things that I always try to tell people is from the minute I get to the hospital in the morning, my goal is to get out as soon as possible to be home with my family. And I think too many people lollygag at the hospital. It's a comfort zone. And that shouldn't be a comfort zone. We need to make home that comfort zone.
That's great.
That's great advice.
Yeah, that's good life advice. Ed, just to get back to spine a little bit, since a lot of people are interested in that part, our careers as old guys, we've spanned 4 decades when spine's come such a long way. From pedicle screws to infused to motion preservation to minimally invasive and endoscopic. How did you look at it with your engineering background and kind of realize that spine and biomechanics and instrumentation was going to be right up your alley? I mean, was it just the serendipitous thing, or did you embrace it early on and try to make it more part of your practice?
Well, I had written a chapter for a book in the mid-'90s, and my spine fellow says, you really need to put this into book form. And I did eventually, the Biomechanics of Spine Stabilization. And you would think that a neurosurgeon who did something like that would at least have a degree in mechanical engineering or biomedical engineering. Mine was chemical engineering. Really bending moments and moment arms and loads and forces really didn't apply too much there, nearly as much as thermodynamics and flow theory and that kind of thing. But what's similar in all of those subspecialties within engineering is the analytical thinking. And so I was able to, I think, put together something that was easy to understand, at least in my opinion. And at the time, the only tome in that regard was White and Punjabi. And although I felt it was great, I felt it also was difficult to read. And so I try to put it all into, and Jens is holding up the book, so free advertisement. Put things in a way that I understood it and that other people could understand it. There's been 3 editions of that book. But that's sort of my biomechanics story, trying to make it keep it simple.
Love it.
And I think that one of the biggest faults of surgeons then and now is not really applying biomechanical principles, just kind of having a gut reaction of what the right thing to do is, not basically look at and analyze the foundations of our decision-making process.
Yeah, I really want to personally thank you for having written it in a way that even I can understand it, and the wealth. I mean, when fellows ask me, what book should I get? I always tell them, this is your first book, because the treasure trove of historic implants and the biomechanical implications is priceless. And no Google or whatever search will ever come anything close to this kind of a tome. Yes, it's a schlep, but yes, it's well worth it. And so this is always my first go-to. The second one is Get Your Complications book. But this is still my go-to recommendation for all my residents and fellows. So thank you.
Well, thank you. I'll tell you, somebody asked me, I've done 3 editions, and somebody asked me, are you going to do a 4th one? And I says, no way. It's just too much of an effort. That whole thing is written by me.
Yeah.
And I'm not doing that again.
No.
However, people are working on a question and answer for each chapter in that book, question and answer book that would accompany that book. So I said, I'll do that as long as somebody else is writing it. I'm lazy.
I don't think so.
Ed, what were your favorite operations? What did you remember liking the most and kind of miss the most?
Well, that's an interesting question, because favorite operation depends on the era in your career that you were dealing with. When I grew up, the lateral extracavitary approach to thoracolumbar trauma and tumors was the thing. Sanford Larson had done major modifications on earlier works, and I'd written a bunch of papers on that. I became interested in cervical spondylotic myelopathy. And so let me go back. I'm sorry. The lateral extracavitary decompression and fusion had a short life and then died out. It was too difficult. There was great potential for blood loss. It did afford the ability to do a ventral and dorsal operation through the same incision, which was all great. But with technologies and surgical experience, there are better ways. In the old days, I was looking. I just got today a request to use the modified Japanese Orthopedic Association cervical spondylosis scale. And so I don't think most people know where that came from, and probably most people don't know that I modified the JOA, because it didn't apply to people who don't use chopsticks. And so I just put in some questions for that. And still to this day, I get about 5, 6, 7 requests every year to be able to use that MJOA, and there's no copyright issues with it anymore. But the article where this was introduced was an article on dentate ligament section for the management of cervical spondylotic myelopathy. And Larson, during my training, did a few dentate ligament sections, and I could, in most cases, you could see the spinal cord coming back after a laminectomy. And so I wrote a paper comparing that with anterior cervical decompression and fusion without plating, because this was in the era before the Caspar plate and other plates. So when you think about what we had the tools we had to use to accomplish the decompression of somebody who's myelopathic in the cervical spine, were not great choices. But the overall, the dentate ligament section ultimately died out, as it should, with better techniques and stabilization techniques, et cetera. And so fast forward now, an operation that I didn't even know about. In those days, I'm sure it had been used in Korea and Japan, is the laminoplasty operation. And people ask me, what's your favorite operation today? And I say laminoplasty, and they say, why? And I says, because people get better. I mean, and I enjoy so much taking care of people with a disability rather than people complaining of pain. And people with myelopathy, and that being their only complaint, you have a good chance of helping them.
So I want to recognize your senior mentorship and authorship in that, for me, landmark paper from 21 from JAMA, the equipoise trial for myelopathy, front versus back. And again, it was music to our ears that laminoplasty actually was probably, if you really look at it, the leading procedure, lowest complication rate, lowest pain scores, right?
Right. and lowest cost for surgery. At a year, it was neck and neck with the anterior approach. The posterior approach lagged behind, and I think that's because it's difficult to maintain or obtain good lordosis, and the patients end up with postural-related pain. But the advantage of the laminoplasty at a year started pulling away from the anterior approaches. And, one of the nice things about laminoplasty is it burns no bridges. You can still do a posterior fusion. You can still do an anterior decompression infusion if you need to.
You have a lot of laminoplasty fans in front of you here. One of the neat things in a teaching institution, it's a great teaching operation because the pathology is open, it's technically demanding, and kind of instantly rewarding because you can see the decompression happen. And the next morning when you go in and patients are feeling things they hadn't felt before, tremendously rewarding. So we all became fans early on.
So, but there are people who don't get better. And I always tell patients, I say there are two kinds of neurons that aren't working. One group are stunned. They're being squeezed. They're still alive. They're being squeezed, but they're not firing. If you take the pressure off, they can start firing and you can recover some function. But the other group are dead. And we don't know how many are stunned versus how many are dead. And I try to ingrain that into patients because invariably there will be the patient who just can't accept not getting better with the surgery.
Ed, let me ask this.
Sorry, I think a lot has to do with the expectations. So, Ed, this brings up a great point about laminoplasty. We are all fans of it, but we have people or surgeons in our group, even the community, and they think it's much easier and faster to do a laminectomy and a multiple level fusion, which I think creates more disability for the patient than the good we're trying to do for them compared to laminoplasty, assuming they're a candidate for laminoplasty.
Yeah. I couldn't agree more. I think that of the three operations, I think that laminectomy infusion is the worst because it's so you're with compare and contrast that with the posterior fusion with the anterior interbody fusion with the ACDF. With the ACDF, you're getting pretty controlled lordosis. You can really more or less dictate how much lordosis you're going to provide for the patient. You can't do that with a posterior approach. You can't exert the forces and moment necessary to give them an adequate lordosis. And if you don't give them an adequate lordosis, they're going to be miserable.
So, Ed, let me ask you a bigger question about myelopathy. Again, music to my ears, and a complete laminoplasty fan. And we're somehow not seeing it as prevalent enough taught, I think, around the country as it should be. But going one step in front of that, I am still amazed how many patients with severe advanced myelopathy present to our clinics that have just been missed by the medical system, even by neurologists. They have higher grade neuric scores, very low, and I'll now rename that no longer MJOA, but BJOA, so the Benzel Japanese orthopedic score. But they have poor scores. They're very advanced in the disease process, and they were just missed. How can that be? Are we not teaching enough about myelopathy?
The medical students don't spend time with us. And so therefore they never are exposed to this. I often say to people that cervical spondylotic myelopathy is the only treatable cause of old age. I mean, people think they're getting old, okay? And their doctor's telling them they're getting old. But in reality, they have a compressive myelopathy.
So true. And why are we statistically, so this was the breakthrough thing for me in the 21 JAMA article, why are we not seeing far more laminoplasties being done compared to fusions, front or back or whatever?
Well, I don't know the right answer. Laminoplasty is beating out anterior approaches, but not by much. And some of that could be surgeon related as well. And one of my partners is aggressive regarding anterior approaches, and he has great results. some people drive Chevys and some people drive Fords. You can't really dictate to people what they should do unless there's clear evidence that black Fords perform better than white Chevys.
That's a Benzelism, by the way. I've heard that one about 100 times, and that's great. Thanks for the reminder about the Chevys and the Fords.
Yeah.
You might have to substitute some electric cars, Ed.
Okay. Well, yeah. I'm a fan of the thermal combustion engine, but at some point,
one thing we didn't mention is that, I think the laminoplasty is technically a very, very difficult operation to do properly. But if you become proficient, it's a very efficient way of decompressing the canal. But unfortunately, with the insurance reimbursement, there's not a lot of incentive. So, Jens, you were saying you wonder why more people don't embrace it. And unfortunately, I hate to say it, it is about money. And, we're not any of us here, but for a lot of folks out in the community, it's a lot easier to whip off the lamina, 3, 4, 5 lamina and throw in the screws instead of trying to preserve the motion.
Right. I think the motion preservation is critical. And, I see much less neck pain in that patient population than the old days when I did more fusions, posterior fusions. Let me just say this too. I know that I was asked to talk about what you do to make an operation successful. I think pick the right patient. I think so often, particularly in lumbar degenerative disease, we're operating on patients with chronic pain syndromes rather than a mechanical back pain related to a degenerative spondylolisthesis. I think we also are not meticulous with regard to laminoplasty, and I think it's a good place to start. When we get a good, clean, dry spine with the muscle adequately retracted, it's going to be a good case before we start. If we're fighting blood loss and we're being a little sloppy, we're going to suffer, and so is the patient as we proceed through the case.
Well said. Ed, let me ask you about, so your bandwidth of articles and scientific work is simply incredible, but let's go into the future and the help of decision-making. So you talked about decision-making, and thank you for publishing in Global Spine Journal. I have a little conflict of interest, but thank you all the more for not going into your wonderful journal, which is, by the way, great. I mean, World of Neurosurgery is fantastic. Artificial intelligence, machine learning, buzzwords all over. Do you see them taking a role in decision-making for instance, let's say neck surgery, anterior, posterior, motion preservation, not? Is that not something where this might apply, and where do you see the application of these newer, evolving cognitive and decision-making technologies?
First of all, let's start off with the simple example of a patient with back pain. They come to see us with back pain, and they have a degenerative spondy. And you say, well, that degenerative spondy is a diagnosis. No, it's not. It's an anatomical finding. The diagnosis is the syndrome that the patient is portraying. Does the patient say, I have deep and agonizing pain that is worsened with loading and improved with unloading, i.e. mechanical pain, that I might be able to help with a stabilization procedure? Or do they have 24/7 pain that is worse at nighttime, pain that keeps them from having a good night's sleep? They're chronically fatigued, often on anxiolytics, etc. Those two patients with the same imaging study are going to have very different outcomes with surgery. So patient selection becomes critical.
So is that something that you'd entrust a anonymized kind of a decision-making tool with multiple variable input potential, or is that something that still relies within the neurocognitive and psychological skills of a direct examiner and practitioner?
I was afraid you were going to push me on this one. Okay, I'll give you my real thoughts. I think it's a darn shame that we can't police ourselves and sort these patients out. And when I say we, I mean all of us are guilty at some point in time, some much more than others. Some don't want to sort it out because we talked about the money. I mean, you don't get paid for making a good diagnosis. You get paid for doing an operation. But the good thing about AI is that it can probably sort that out for us if we let it. It can tell us not necessarily who should have an operation, but it can hopefully tell us who shouldn't have an operation. And we should be able to figure the rest out. I mean, if they can sort out the difference between the patient that has deep and agonizing pain that is worsened with loading and improved with unloading from the patient who has pain 24/7, non-restorative sleep, chronic fatigue, etc. Again, that seems so easy. Any of us should be able to do that. But machines may do that for us with authority in the future because it's going to be backed by insurance companies.
But Ed, how about the value in the art of medicine? As people who have been doing this for 4 decades, hopefully you have a sixth sense in addition to your academic knowledge base. There's also a way of assessing whether a patient has other issues that may be contributing and may make them a poor outcome or a better outcome with a little extra help from an allied health person. They may need their back fixed, but also their psyche fixed. And I don't know that a chatbot's going to be able to do that. And, that's kind of the fear, is that people are going to be following a cookbook, and there's the loss of the empathetic art part of medicine.
Yeah. I think you're absolutely right. There's some patients that have a chronic pain component, but an underlying significant anatomical problem, say like a huge herniated disc. I think the art form there is to fix, if you can, fix the psychosocial issues before you delve into surgery, because even a good operation may have a bad outcome if you don't. But so, I dodged your question too. Is there risk in a machine telling us that? I think there is. I think there needs to, at some point, be some sort of override, just like there is for cars that drive themselves. There's got to be, the driver, the human being, has to have an override of this mechanical system.
And I think that's a great analogy. As you say, with the self-driving cars, you can take them over. I see AI as sort of an assistive device to help the practitioner not overlook something. Say, it still doesn't, we still have our judgment, but it'll help them say, like, did you consider so-and-so? Did you consider this, or did you consider that? And that may be helpful.
Yeah, but I think we need to get more surgeons talking about chronic pain and chronic pain syndromes and what they mean and how we can't treat them. Somebody else needs to be treating them, at least up front.
So I want to put one of Jack's comments just a little further. Jack, you talked about the 4 decades and someone 2 years in their practice. How do you impart that knowledge, that experience to the juniors? And Ed, you've been exceptional with all the courses, the courses in Turkey and in Egypt and in South America and in China and all over. So what's your strategy to impart your experience on those surgeons that are just starting right now, so that they benefit, and ultimately the patients benefit from your 40 years?
I wish I could tell you that I've got a perfect track record and everybody that I taught did what I said. But that is not true at all.
Look at Izzy.
Yeah.
I got lucky.
I think it's really tough. I mean, put yourself in their position too. They're being hired at a hospital or into a practice in which production is part of the equation, and production isn't measured by the good they do. production is measured by how much they do. And somehow we have to change our reimbursement system to a system that pays for the good we do, not how much we do.
There's a great.
But to answer your question, I'll have trained somebody, and then they, and I thought I got the message. I thought they got the slip and they knew what was going on, and then they call me and ask me something totally off the wall. Should I use huge operation X or huge operation Y for this patient who didn't need surgery in the first place? And so, you can take a horse to water, but you can't make him drink. Is that the analogy, or is it a camel?
I think
either one.
Either or, exactly.
Measured twice, cut once. There was a great article of yours in 2014 to the point, and that's recurrent disc herniations in the lumbar spine. Should you decompress? Should you fuse? It was a questionnaire-based thing, I think, published in the Spine Journal. And this is one of those landmark studies that I think serves this point very well. Older surgeons tended to do a revision decompression, and I see this in my practice all the time. I came from clinic right now. Younger surgeons want to fuse these patients, and there's still some older people around, but this is just one of those weird experiential things. As an older surgeon, been around the block, a revision decompression seems to be just fine. So can you expand on your experience with that article and how that transcended into other areas in spine surgery?
Well, you just sort of did that. I mean, talking about the art of surgery. I mean, the art of surgery is somehow knowing the right thing to do. I mean, and the right thing to do, think twice, act once, to use that expression, to extend that expression. Think twice. Do I really need to do all of that? Do I really need to? And what is today's problem? We need to fix today's problem today and tomorrow's problem tomorrow. That's an Ian Kalfas-ism, by the way.
Oh, is he?
You know what we try to teach the fellows is to do the family test. In other words, do what you would want for your family member or yourself.
Sure. Absolutely. How often do you get how often would they still do the wrong thing for their family member or themselves?
So,
well, I think you're right, Ed. I've seen that. One of my former colleagues ran home from a meeting to operate on his mother because he was sure she had myelopathy, had his associate operate on her. And then I saw him 3 months later, well, how's your mom doing? Well, she had ALS. And, he didn't really evaluate her and couldn't take off the blinders and see everything. And that's why he ran his practice too.
Wow.
So if we then assume that there's a merit to older surgeons with their wisdom, greater bandwidth, and maybe less economic focus on their surgical types of practices, how can we, as we need more spine doctors and surgeons with an aging and ever sicker population, kind of transition or make good use of surgeons with experience? Meaning, in Europe, we have brilliant people, colleagues of ours, who get mandatorily retired at age 65, Germany, Italy. How can we have a good role that is safe for all participants, for aging surgeons like yourself, myself? I just had my 64th birthday, while we're protecting society's interest.
Your baby ends.
So this gets into the concept of retirement. And by the way, I recommend a book, and I don't know the author's name, the book's title is The New Retire Mentality. He just goes into what we should be thinking about 10, 15, 20 years before age of retirement, so we're prepared for it, because I'm totally ill-prepared. I'm 74, be 75 in December, and I went half-time. I take the first 2 weeks of each month off, and so I have a mini vacation every month. I just got back today from a camping trip with my wife. But that has its downside too, because squeezing patients into the funnel and trying to get them into the operating room. I gave several cases away because I couldn't be there because they were deteriorating or whatever, and I wasn't going to be in town at the time of their surgery. And maybe that's the role for the experienced surgeon, to become a feeder, if you will, of the younger folks in the practice, and maybe stick your nose into the surgery occasionally if that's appropriate. The thing that bothers me the most is the diminished exposure to the residents and fellows. That's sort of what keeps me operating and sort of what keeps me going here. And if that that generator of interest for me is decreasing, I may face retirement sooner. The trouble is, I don't if it's a rainy day, I don't know what to do with myself. And that's where planning on these kind of things in advance may be helpful. I have a partner, Rich Schlink, who took up about 5 years ago making guitars, and they are beautiful, and he donates them, etc. But he's got it figured out what he's going to do after he retires.
Ed, just a question about disc replacement, which is near to our hearts. I know you and Izzy were early people in development of a lumbar disc while you were both at the clinic. Any good stories about that, or regrets, or wish we had done something a little different, or maybe we shouldn't have bothered with it in the first place? How do you feel about that?
Well, that's tough, because I think we had first of all, I have never put in an artificial disc in a living human being. I am still not convinced. And so we probably are at odds in regards to our philosophy. Having said that, I think we were really onto something with the disc that Izzy and I were working on. And, we ran out of money. I think that some poor misjudgment was made. And that's the way life goes. Izzy, I'd be interested in your comments on
that. We have to give a shout out to Ray Ross as well, because
yes.
pretty formidable team. I learned a lot from Ray and from Ed working on the disc replacement concept. Ed, from the orthopedic background, life is motion. Everything's got to move. I do feel that there is absolute merit to preserving motion. I don't know that we have the right answer now. Being at Texas Back Institute now 13 years, I see the successes that they've been putting through, and they're very critical internally of their work. So we still have a lot to learn, as with everything. The project that we were involved in, was pretty good. It's a shame we didn't get it to where it needs to be. But there's a lot of smart people working on this, and it's going to be very much like orthopedic hip, knee, shoulder, elbow replacement. None of those worked for the first 10 years, 12 years, 15 years very well. I remember as a resident putting in the Macintosh knee replacements, which was just a sliver of stainless steel that you put in there, no anchoring, nothing. And then those things just fell apart. Right? But it started somewhere, and now look where it's at. So that's where I think we're at with disc replacement, and it's going to get better.
Well, I don't doubt that, but yes.
No, go ahead, Ed.
What was I going to say? I don't doubt what you say is true. but that the angst associated with these decision-making processes in patients with pain and how it's hard, I think very difficult to sort out pain patients. Pain is a difficult parameter to operate on. And it's the reason that when I narrowed my practice a couple of years ago, I said, I'm not going to do lumbar degenerative disease anymore. The angst, the decision-making process, the patient population to me, and to be quite honest with you and transparent, I wasn't up to date. I mean, that's another thing when you face retirement and you're almost 75 and you say, man, I go into the operating room and see what some of my partners are doing for lumbar fusions. I say, this is slick. And I'm not the right person anymore. Some people are, windows open and the right person arises. And then when the windows start to close, there's another person.
But Ed, it goes back to what you were talking about before, which is pick the patients right. And the one thing that attracted me when I moved to Texas back was they were one of the first groups that had an algorithmic approach to working up patients with back pain. And the IDE studies, the FDA studies for disc replacement, sort of forced that really into a corner where you had to identify patients who were in a box. And the whole point was weed out everybody else, but just pick these people and let's follow them for 2 years, 5 years, 10 years. And that's what we've been doing for the last half of our careers. And we're pretty convinced if you pick the right patient, it is the right operation. But the corollary is the opposite's true also. You pick the wrong patient, you can do the most beautiful looking x-ray operation, and you're not going to have a happy patient. So
yeah, you're doing it the right way. How many people don't do that?
Sure. No, but that's true about any operation.
Mm-hmm. Yeah.
So Ed, looking, as you mentioned, you're going in. Oh, sorry, you go ahead. Go ahead, Rick.
I was going to ask, so, Izzy said, motion is life. And we talked about, your biomechanical background, Ed. So, people are doing these long fusions in patients of all different ages. And I just can't help think that there's got to be a better way, because we're going to look back, maybe we won't, but, our younger colleagues will look back and say, I can't believe we put all this metal in from T4 down to the sacrum. We did the bedrock procedure across the SI joint. I mean, what do you think is the future of that? Do you really think that we're going to continue to do that, or we're going to come up with better ways?
There's got to be a better way. Deformity surgery spells a lot of complications and a lot of money. And, I watch our deformity guys. I go to the deformity conference and watch them anguish over the right thing to do. Worried about PJK and, failure of the constructs. And, the bottom line of all of that is the patient going to be happier? So the flip side of that is, if somebody's miserable, are you just going to let them be miserable? And are there other ways of taking care of the problems? I mean, if the patient's falling apart with the scoliosis and the kyphosis and poor bone quality, sometimes you probably have to go from high thoracic to the pelvis. Now, not me, but a capable surgeon.
So we'll have to close soon, but Ed, if you look back on this amazing career of yours, looking at all the various technologies that you've seen, some come, some go, what was the biggest breakthrough that you think in the big picture that you saw that is kind of the most inspiring for you as you look back that's now in vogue? Was it disc arthroplasty? Was it less invasive surgery? Was it guidance systems? What sticks out in your mind?
If you're looking at spinal cord injury, I'm going to make a sort of a tongue-in-cheek remark here. The major treatment modality that had the biggest impact on patients with spinal cord injury was a volume ventilator, followed by skin care, not surgical techniques. I don't know that I can answer that question. I mean, I'm not a technology guy. I mean, you could say, well, laminoplasty. I mean, we all like laminoplasty. We've all agreed on that. Maybe that's the biggest and best. I think image guidance, though, and has been a major advantage, and that it will continue to evolve and become even more valuable as time passes.
Ed, thank you so much for doing this, for introducing yourself to a lot of folks listening in, and for cementing our belief that you're one of the good guys in spine and in the world. So enjoy your semi-retirement, and we hope we stay in touch.
Okay. Thank you all.
Thank you very much.
You bet.
Thank you, Ed. It's always an honor and a privilege, and I miss you, buddy.
I miss you too. Those were the good old days.
So, Ed, personal wish, keep on running, and hope to see you around here in Seattle, back close towards your roots, live at one of our courses here. It's so good to see you.
Okay.
You're fantastic.
Okay.
Sound even
Thank
better.
you, guys.
Take care.
Stay well, everybody.